Right, good morning. I think we may start now. I wanted to welcome everybody for joining us today in Wales. Joe told me we were earlier in Belfast and we are now in the UK, in Wales, where we are going to meet with Andrea Croft. Andrea is a nurse practitioner, the Princess of Wales in the south of Wales, and a nursing director for our charity Thrombosis UK. And she's been a very active component of the All Wales Hospital Acquired Steering Group, which has started in 2014, and since there are very good results. And Andrea is going to present us these results and the process she went on to do that. I would like to remind everybody that the video will be available on the Thrombosis UK website in a few hours. And we would like to thank all the sponsors for their help. And I have been earlier in a virtual presentation by a sponsor, and I would invite you to join in. It's very interesting, a very different experience. Andrea, we are welcoming you and listening to you now.
Okay, thank you very much for that introduction, Stephane. It's very nice to see you and Joe, and welcome to everybody who's joining us for this session this morning. So I wanted to talk about the impact of an All Wales Hospital Acquired Thrombosis Steering Group and just go through the journey that we took as a group in Wales, which is quite a few slides, I'm afraid, but I'll try and get through them in about 20 minutes. And then if anybody's got any questions, perhaps you'd like to ask at the end. So I have nothing to disclose. So just a bit of background first. So in 2012, approximately 900 people in Wales were reported as dying from venous thromboembolism, or as we know, VTE related causes. Not all of the deaths were avoidable, but many may have been. And many survivors of deep vein thrombosis suffer long-term physical and psychological effects. And Paul Bennett's going to be doing a good session tomorrow on the psychological effects of VTE. So that's worth having a look if anybody's interested. And most cases of VTE occur during or following a hospital admission. So since the publication of the recommendations of the Welsh Assembly Government's one-day inquiry into hospital-acquired thrombosis in 2012, NHS Wales clinicians and Welsh Government have been working together, supported by 1,000 Lives Improvement Programme, to improve the situation for patients admitted into Welsh hospitals. This collaborative was a way of working, has been recognised in other parts of the United Kingdom as good practice, and we've been asked by other parts of the UK, such as Scotland and Ireland, to how they can adopt it for their own countries. So that's really, really exciting for us. So Wales has been recognised for excellence, and 4 sites have now been granted the title of VT Exemplar Centre. The Princess of Wales and Maesteg Hospitals, Neath Port Talbot, Ysbyty Crwyd and Wrexham Maelor have all been recognised. This is a prestigious status, and I'm going to be talking about this on Friday afternoon if anybody wants to tap into that and hear how you can all become exemplar centres. The award is made by the King's College Hospital London, who are recognised as world leaders in this field. Other services have been recipients of national awards for innovation, service improvement, increasing research capacity and cross-boundary working in the field of venous thromboembolism prevention in Wales. So we've all been very busy. So with the support of the Welsh Government, we can now evidence that health boards are not only collecting and analysing data on patients who may have had a hospital-acquired thrombosis, but we've also identified where there have been potential system failures and implemented improvement measures. There's still some way to go, particularly in identifying patients who may have died in the community, and it's vital that a good relationship and reporting mechanisms are developed with medical examiners when they come on stream in 2020. Of course, COVID being here during the majority of this year has had quite an effect on any new services that were due to be started. So that's something that's hopefully going to happen. There are also other areas to study, such as patients who have had a hospital stay of less than 24 hours. So day case patients, there's patients coming in for blood transfusions or coming in for knee surgery as day cases. Patients who have had a lower limb immobilised for an extended period of time. The HAT steering group is an existing forum where these issues and other areas of concern can be resolved on a national basis. So the House of Commons Health Select Committee reported in 2005 that between 25,000 and 32,000 people are at risk of death each year in the UK because of a pulmonary embolism following a deep vein thrombosis or other venous thromboembolism. The amount proportioned to Wales equates to approximately 1,250 people. Not all of these deaths are avoidable, but with appropriate thromboprophylaxis, many are. The VTE can have a long-term effect on survivors, with up to 40% of DVTs leading to a chronic condition called post-thrombotic syndrome. Research undertaken in Wales has identified long-lasting psychological complications with some symptoms suggestive of post-traumatic stress disorder. Most cases of VTE occur following a hospital stay. In fact, you're 6 times more likely to develop a clot associated with a stay in hospital than from air travel. These are known as hospital-acquired thrombosis. However, most of these cases, as I've said previously, can be prevented with simple preventative measures, early risk assessment, and appropriate thromboprophylaxis treatment. In 2012, following the one-day inquiry by the Health and Social Care Committee, Welsh Government issued recommendations to NHS Wales to encourage improvement. These recommendations were: 1, make reporting of HAT a Tier 1 priority. This is our equivalent to the sequin payment that was in England. Now, unfortunately in Wales, we never had any financial incentives. We had a carrot and a stick. And we had to be very innovative how we went about increasing our uptake of risk assessment and appropriate treatment. So that was quite a challenge. The mandating of risk assessment and thromboprophylaxis in all Welsh health boards. We wanted to develop a standardised HAT rate. The recommendation to undertake a root cause analysis of all hospital-acquired thrombosis and increase clinician and public awareness. The All Wales HAT Steering Group was set up to implement the recommendations under the chairmanship of Professor Simon Noble, who is the Aneurin Bevan University Health Board and also Cardiff University. And Simon is the Welsh Medical Director of Thrombosis UK. He's now the overall Medical Director of Thrombosis UK, who at the time was Professor Beverly Hunt, who was also a member of the steering group. And Beverly is stationed normally in Guy's and St Thomas's in London. So the steering group agreed the definition of HAT and a methodology for collecting potential HAT incidents. The methodology included using RADIS, the Common Radiology IT system for Wales. Importantly, they recommended changing the reporting measure from HAT rate to HAT incidents. This provided emphasis of potential harm to individual patients and provided more beneficial in engaging NHS staff. So instead of looking at a number and a percentage point, we actually looked at real people, which made it easier to engage. The group also developed and agreed a risk assessment process working in collaboration with the All Wales Medication Chart Group. This resulted in a new section being added to the front page of the All Wales Inpatient Medication Chart that made it easier to ascertain whether a patient had been risk assessed and whether the correct thromboprophylaxis had been prescribed. And this tool was rolled out across the whole of Wales, so every one of the 7 Welsh health boards uses the same inpatient medication chart. Now, not all VTEs can be avoided, and so the group wanted to create a measurement system that identified those potential cases that could have been avoided if the correct steps had been followed. Therefore, a screening tool was included in the reporting mechanism. Potentially avoidable HATs were identified by asking 2 simple questions. Was a VTE risk assessment carried out? Was the appropriate thromboprophylaxis given? If the answer to either question was no, then the case needed to be investigated further. In 2014, this was all linked to Welsh Government's Tier 1 reporting mechanism, where health boards were required to report the number of potential hats identified monthly, the number of hats that were potentially avoidable quarterly, and lessons learned from a subsequent root cause analysis. We increased clinician and public awareness and developed the Ask About Clots campaign. So working with 1,000 Lives, which was a public-facing campaign to improve the care and health of people in Wales, Ask About Clots was developed and launched. Resources from the campaign are still in use and messages are seen all over hospitals in Wales. So as you can see, we had banners, we had leaflets, we had posters, we had video recordings that went across screens in different departments. And it was a very successful campaign, very colourful and very easy to understand. And as with all documentation in Wales, everything was done in Welsh and English. So although the Ask About Clots campaign was primarily designed for the general public, it was noticeable in supporting the spread of the campaign throughout hospital sites. NHS staff, both clinical and non-clinical, reported improved knowledge of the subject due to the campaign, which was probably due to the ease of the diagrams, the pictures, the language, and so that was really useful. In addition to the Ask About Clots campaign, 1,000 Lives working with Velindre Cancer Care and Anticoagulation Europe, now Anticoagulation UK, supported the production and distribution of a resource to support patients undergoing chemotherapy who were at an increased risk of thrombosis. This video resource can be found at this link, and further information can be accessed at this website. The project is ongoing in Velindre Hospital and has been evaluated through grant assistance from the Tenebus charity. Results on this evaluation are due to be presented at the International Conference on Thrombosis and Hemostasis in Cancer, due to be held in Bergamo in Italy in April 2021. So the greatest improvements that have been made in the promotion of reporting, reviewing and reacting to the potential incidents. In September 2014, Welsh Government informed all health boards and Velindre NHS Health Trust that the HAT National Steering Group had agreed the mechanisms to be put in place to collect data on the number of patients who may have had a potentially preventable HAT. As a result, it was advised that this data, along with a summary of learning, would be reported to Welsh Government as a Tier 1 measure. Every health board now collects and reports potential HAT incidents to Welsh Government. They also report how many of these incidents have been root cause analysed and what lessons have been learned. Recent analysis shows that this has also had the effect on increasing the number of assessments performed in a virtual circle that could report in the number of incidents decreasing. This positive approach to Welsh Government and NHS Wales clinicians working collaboratively to improve patient safety has been presented in other countries of the UK. It has been recognised as good practice. We demonstrated standardised practice with the implementation of the amended All Wales medication chart, which has led to an increase in the number of assessments undertaken in all Welsh hospitals. This is identified as a key process step that can lead to a reduction in hospital-acquired thrombosis. So this is our root cause analysis tool. I'm not sure if you can see it very well. On the left-hand side is the monthly reporting. And as you can see at the bottom, you've got April, May, June. This is actually what was presented to Welsh, or sent to Welsh Government in 2017. So this is actual data. So in April 2017, 12 patients were identified as suffering VTE either during a hospital stay or following 90 days post-discharge. And that was the same for each of those months. So every month, those figures are taken off of RADIS. We establish through RADIS which ones were developed the clot when they were in hospital or up to 90 days, and that's extrapolated from the total amount of VTEs that were suffered by patients during that month. So that could be community patients, it could be patients who presented possibly coming back from a holiday, and not potentially preventable or hospital acquired. On the right hand side, you'll see that we've got quarterly reporting. So looking at April, May and June, that was our first quarter for 2017, and that total came to 33. So if you look on the right hand table in quarter one, we've got 33 patients, which was the number of VTE cases which were associated with hospital admission or up to the 90 days post-discharge. Of those, 5 sets of notes were missing. So of the 28 sets of notes that were available for a root cause analysis, 27 were found to have not suffered a potentially preventable HAT, but 1 had suffered a potentially preventable HAT. That 1 person then is, all of those figures are reported to Welsh Assembly Government, but that 1 person is reported back to the clinician who was responsible for that patient's care during the time that their treatment or their care wasn't appropriate. So if we look at the potentially preventable HATs, and this is the data that we get them from sending to Welsh Government. So looking between 2016 and 2019, unfortunately, when COVID broke out, we had to temporarily suspend our reporting because the majority of people who were involved in the group went to work in other areas such as ITU or in the community or on the general wards. So looking at this, you can see a downward trend from 2016 to 2019 of the number of potentially preventable HATs. So we're really pleased that we've been able to demonstrate that the work we have done has been successful. This is a page that was taken from, I can't think what it's called. It's basically information that's been taken to demonstrate the number of VTEs that were identified through the RADIS. That's the spiky blue line at the top. It's a dashboard, sorry. The red and blue line below that demonstrates the number of patients that have been risk assessed and reassessed. And as you can see, that number has been steadily above 80% and climbing. And at the bottom, we can see specialities and sites and different wards where there have been increased numbers of VTEs, where patients had developed a clot either due as a patient or up to 90 days post-discharge. So this is a really, really good tool because we can look at this and we can see which areas we need to identify and focus on to give a little extra training or to go and chat with the clinicians to see what's actually happening and why those particular areas are having more incidents of VTEs than other areas. More results here. The graph on the left-hand side demonstrates the increase in the uptake of risk assessment and reassessment, which is the blue and red line, compared with the downturn of HATs, which is the downward green line. So again, that demonstrates between 2000 and 2018. 2013, 2018. And then the graph on the right, that's again a very good graph. The blue and red lines at the top demonstrate the increase in the uptake of risk assessment and the downturn of potentially preventable HATs. And the blue line is the compliance with the uptake of the risk assessment when the All Wales medication chart was put in place. And that was January 2016. And there's undoubtedly a step up from that date when the risk assessment figures went significantly higher.
Andrea?
Yes.
Can I just, you've been talking very well there. Can I just got a couple of questions that I wanted to ask you, which might be relevant to this coming on the chat there. People wanted to know who typically assesses the patients in Wales. We do have some issues in places where there are some not conflicts but discussions between the consultants and nurses on who should do what. What is typically your approach in Wales?
In Wales, I would say typically it is the person prescribing the thromboprophylaxis. So it could be predominantly clinician, the doctor who's admitting the patient or doing the first review after the patient's been admitted within the first 24 hours, or it could be a nurse practitioner who's an independent prescriber. It could be a pharmacist who's an independent prescriber if they're doing the admission. So while I can understand some areas feel that nurses are in the best position, personally, I feel nurses are in a better position for the reassessment, because the nurse is on the ward all the time and they're in a position to be able to assess the patient's condition as they spend majority of the time with the patient. So probably better.
The other thing is in England we have so we have 4 assessments. We got one in outpatient, one on admission, one at the end of the surgery, and then we reassess. Is there what is the protocol for you in Wales? How many times you assess patients? And for an inpatient, let's go for an inpatient.
Well, again, it probably differs in all of the different health boards, and it's a good point actually, because I don't believe we have a standardised approach for that. I could tell you what we do in our health board, but I would say that most likely patients are risk assessed on admission, reassessed at the first consultant review, if that's appropriate, and then reassessed daily or as the patient's condition changes as per the NICE guidance.
Right.
With regard to an actual tool for reassessment, I believe there is only one tool being used in Wales specifically for that task, and that's a daily tool. But that's something that we perhaps should look at, a consistency of across the board, that we're all reassessing at the same time.
Excellent. That's all the questions for now. I'll show you some more later.
Okay, thank you.
Thank
Okay,
you.
so continuing. So the VT Exemplar Centres in Wales, the Exemplar Centre network was established in 2007 by the Department of Health in England with the aim of using network leadership to reduce avoidable death, disability and chronic ill health from hospital-acquired VTE. The VTE Exemplar Centres have an existing track record of excellence in VTE prevention and care, and offer practical support and advice to other centres by sharing their resources and collaborating on clinical research into VTE prevention. So member centres include the public and private sector, large teaching hospital specialist centres, DGHs, and Rupen Arya, Professor and Director of King's Thrombosis Centre, leads the network. The first VTE Exemplar Centres in Wales were awarded to the Princess of Wales in Bridgend, Maesteg General and Neath Talbot hospitals in 2015. In 2018, we saw successful applications from Betsy Cadwallader, with Ysbyty Glân Clwyd and Wrexham Mailer being also granted as exemplar status. The steering group is well placed to provide support to other NHS Wales sites and advise them on how to gain this exemplar status in the future. And the experience gained by existing sites would prove invaluable to all future applicants. We generally meet twice a year, the steering group, and we share best practice and our experiences. And certainly there are a lot of individual hospital sites and health boards that are looking to move into exemplar status. We've held annually our National Thrombosis Week meetings, which were originally organised by the Thrombosis UK, and we've held them in Wales for many years. But in 2015, myself, Marilyn Rees, a DVT specialist nurse in UHW, supported by Joe Jerome, CEO of Thrombosis UK, we developed a conference which we've held annually in Cardiff during National Thrombosis Week in May. And the conferences have gone from strength to strength, and we're now up to 150 attendees. We'd attracted UK and international speakers, which included Simon Noble, Dr. Beverly Hunt, Andrea Cohen, and we supported sponsorship from a number of pharmaceutical companies, which allowed NHS staff to attend free of charge. We also attracted the Welsh Minister for Health, Vaughan Gethin, and this year, Mr. Andrew Goodall, the Chief Exec for NHS Wales, was coming to speak. Now that COVID has taken over us all, I doubt very much whether we'll have a face-to-face conference again. And I think the platform that we're now speaking on is going to be our norm. But I personally think that's a good way forward. And I think this conference up to now has demonstrated that this is a really successful platform to share information to a very large audience.
Indeed, and I can see on the list of participants, I've got many countries represented and very different people. Another couple of questions we came up, is that okay with you, Andrea?
Yeah, sure, yeah.
People wanted to know how big is the group? The group for the Wales now, because you started quite small, but now there must be quite a few people.
Yeah, we started off, there was, well, going back to about 2008, when we were affiliated to Thrombosis UK as it was, there was probably about 5 members, and we've pushed forward to get to where we are now. Now we have members from every one of the 7 health boards. So there's probably 3 members from every health board, so that's about 21. We've got membership from Thrombosis UK, and I'll show you a list at the end of who we have. We've got Public Health Wales. We've also got the Royal College of Nursing. And we invite specialist speakers to come in for particular topics. So if there's something that we're either concerned about or something that we're interested in, we'll invite somebody with a specialist interest or knowledge of that subject. So yeah, it can be quite a large group. Generally, there's maybe 1 member from each health board attends, or they come in by video. And we tend to meet in Mid Wales so that it's convenient for our colleagues in North Wales, Mid Wales and South Wales, just to try and make it, accessible to everybody.
I know a few nice places there, yeah.
Oh, lovely.
There's another question that came up, is someone's asking if during the pandemic you're doing some virtual teaching to nursing staff for VT awareness and so on.
Again, unfortunately, I've actually myself been out of the hospital setting since the end of March. And while I have been in contact with some of my colleagues, unfortunately, it's very difficult at the moment to be able to tell you with any certainty what's happening with regard to video sort of linking. I know that there are meetings going on Zoom. I know that there are meetings going on other video platforms with thrombosis groups, but with regards to actual teaching that's happening, I'm afraid I need to get together back with the group once we're in a position to do that, to find out what's going on.
And certainly it's something that Thrombosis UK we can probably centralize the resources and signpost people who want to know what's happening.
Well, I think actually that is something that we have been doing. I was working with a group of medical students in the community, it's about 25, and signposted them to Thrombosis UK, and also gave them our written literature, which has got Thrombosis UK website details on it. So yes, from that point of view, Thrombosis UK is always there as a resource, and it's a resource which I would say that all of the health boards in Wales are aware of and are happy to use.
And there is a package available for NHS staff in the UK, which is on the e-learning for health panel, which is I think it's been done by Ruben Andrea. Yes. Along with the nurse as well. That's a 30 minutes basic tool which can be used very well. I think, let me have a look if I had any other questions here. So I think you've answered that. What type of healthcare professional are on the group? I think you did say there was a multidisciplinary team. Do you have
Yes.
people like physio as well? You said physio, you said pharmacists, nurses. Do you have any physiotherapists on your team?
Yeah, we did have a physio who came along, and obviously pharmacists, nurses, clinicians, midwives. We had somebody who came from, I think we had an OT representative who came along. So yes, we've tried to make the group all inclusive, and that was something that actually came up at the meetings at the end of last year, looking at extending the group. And our first meeting would have been, unfortunately, at the beginning of when COVID started. So again, it's rather thrown everything into disarray, unfortunately. But yes, but one thing I can say, which I was really pleased about, because one thing that COVID has done is it's allowed us all to see how the measures that we've put in place would continue in our absence, because we've all met fairly, recently. We've done our root cause analysis. We've been engaged with our, clinicians and wards and everything. And I was really reassured to look at some figures earlier this week and last week that demonstrated that our uptake rates in a couple of health boards that I looked at were maintained. And I think that's really reassuring that that's continued, even though it's demonstrated that we didn't have to be there pushing people along to do this. This is now embedded in normal practice, and it's continued. Which
is very humbling, because it is very humbling because you didn't have the financial incentive that we had in England with what we call the sequins, because that's how it all started with us in 2010. But you had basically to get your hands dirty to get the product.
We had to be creative.
One of the participants wanted to know, I don't know in Wales if you have the Datix system to report incidents?
Yes, I personally use the Datix system, and I know that some of my colleagues use it, and I believe that the Datix system is a very, very good way to go forward. Some of my colleagues report directly to the clinician, but I find that using the Datix system, it's a recordable incident. It's got a time-limited reporting. We have a measure then that's put in place to demonstrate what clinicians will do to prevent further incidents occurring. And we have a record that we can audit. And I like the Datix system. I think it's a really useful tool. And a lot of clinicians like Datix incidents against them. So it's an
Do you record it only for preventables, or do you record non-preventable as well? Although there is a thin line.
No, we don't generally report those. We would have hundreds, as everybody would. If there was an incident where if there was another incident that was associated, then we would report that, and the fact that the patient had developed a clot may be part of that incident. But unless it was actually potentially preventable and the patient had been mistreated, then we wouldn't report it.
Mm-hmm. And did you observe a spike of PEs or DVTs? Again, a question from a panelist during the pandemic. Has it made a difference, or is perhaps the people have been very busy and they're not reporting anymore, or any tendency?
We need to look at those figures in a different way, because certainly I've been working in ITU during the pandemic, and patients who have been given appropriate thromboprophylaxis but who developed either suspected PEs or confirmed PEs, they're going to need investigating fully. And I think that's going to, for myself, I want to look at those patients in a different way, because we need to look at perhaps more information associated with when they were admitted, the D-dimers that they were taken, what the figures were, what treatments they were given, if they were treated appropriately for the COVID, if they were treated appropriately to the risk assessment tools that were in place in early March when people first started coming in, before we had any COVID risk assessment tools. So I think that's going to need looking at in a completely separate way. We review our ordinary patients, in inverted commas, retrospectively. So those patients are done 3 months retrospectively anyway. But again, at the moment, I only just started putting in my figures about 10 days ago, because I wasn't in a position before that to be able to continue with that.
So no pressure, but if we could have the results by tonight, that's really good.
Yeah, I'll add it to my list, Stephane. I've got a big pile of notes here, things to look through. So I'll try and get it to you by midnight.
So I think that takes us to the end of our little conversation today about heart group in Wales. I want to thank you very much for taking the time during your work day to come and talk to us. And thank you to the attendants, all the participants, and all the questions. That was very interesting.